Hello, I'm Dr. Maurie Markman from City of Hope, and I'd like to discuss what I consider to be an absolutely fascinating paper, and one that I will say is very interesting results, but raises really many more questions than the paper answers. And I think that's the intent of the authors. The paper is entitled Addition of Metastases-Directed Therapy to Systemic Therapy for Oligometastatic Pancreatic Ductal Adenocarcinoma. Extend, that was the name of the study. A multi-center randomized phase 2 trial published in the Journal of Clinical Oncology. You might even say, what? What does it mean? Metastases-directed therapy in pancreas cancer. Have we really made much of an impact on pancreas cancer? In fact, in my earlier years training, I would say that if somebody came up with the idea or suggested as part of a trial or treatment of an individual patient that they would focus on metastases in pancreas cancer, one, you might say they're crazy. Or two, you might say, yeah, but they really just probably don't know anything about the disease and its natural history. Now, fast forward several decades, even with the recognized modest advances in systemic therapy, what we see are tremendous advances, really remarkable advances in innovations in radiation therapy, which of course include not only the use of radiation itself, but the imaging technology that is used to direct the radiation therapy. And these advances have permitted asking the questions that are addressed in the current study. So again, fascinating. What this study did was randomized, very small number. Again, it's a randomized phase 2 study. It's really more of a proof of, does it make sense? Principle here. So they randomized 41 patients with 5 or fewer metastatic lesions, because again, it's oligometastatic disease. You could have numerous lesions, to either undergo what they've described as comprehensive metastases-directed therapy. Most of this was external beam radiation therapy, stereotactic radiation therapy, but there was some localized radiation as well, implants, with plus chemotherapy. So this was these comprehensive metastases-directed therapy to each of these sites, plus chemotherapy versus chemotherapy alone. What was shown in this trial, what was found in this trial, that the PFS in the metastases-directed therapy group was 10.3 months, time to subsequent progression, 10.3 months versus 2.5 months in the group of patients who received chemotherapy only, with a hazard ratio of 0.43 and statistical significance. Remember, this was a very small study, but we see more than a tripling in the PFS. There was no difference in overall survival, which is not at all surprising because it was a very limited sample size, and very importantly, and it was essential to do this trial ethically, that a crossover was permitted at the time of progression, meaning that if a patient received chemotherapy only, progressed, they could potentially get stereotactic radiation to sites of metastatic disease, and they might have also very much benefited from that kind of a strategy to the metastases, so that overall survival in the small population may not be different. But again, a tripling of the time to disease progression. So clearly, a larger study will be required to be more definitive. Maybe more centers involved, maybe some modification in the study design as in this trial because of any issues that the investigators may have identified. And of course, overall survival would be a fair endpoint to look at. But again, crossover would be essential, and that might influence an ultimate outcome. But PFS is a very valid endpoint. And the only other point to mention, and it's a very important point, is with these results, and as I mentioned, advances in radiation, advances in imaging, Is it reasonable to potentially consider this type of approach for individual patients as a component of aggressive standard of care, of course, with very adequate informed consent being provided to patients? We don't know what the impact will be, but with the limited morbidity associated with the radiation, an individual patient with pancreas cancer with an adequate performance status, giving them chemotherapy, but also limited metastases, radiation directed. Is it reasonable to consider that as an appropriate treatment option outside the setting of a clinical trial? I think this is a very valid question, one that needs to be addressed, and one I think, in my opinion, the answer in some settings should be yes. But that needs to be discussed much more widely than simply this randomized phase 2 trial. And I thank you for your attention.